So this instruction course, as you can see, is on optimizing outcomes in challenging cataract cases. So all of us are adept in performing phacoemulsification in simple cases. So this one will focus on a spectrum of complicated cases. We'll start with Professor Jeevan S. Ketyal, who will take us through the role of imaging in cataract surgery in enhancing safety and understanding the intraoperative dynamics. Sir has taken over as President AIOS in this conference. Over to you, sir.
Thank you, Dr. Manpreet. I think thank you so much, AV team, and good afternoon, friends. I think we had a very nice session with Hoya, But the last thing which came out to be, how to learn your surgery. Learning is, from a process, which is, always going to take you further. You should not be stagnant or whatever you're doing. There has to be a prospective learning every day. And each surgery gives you a challenging situation. They are never same. And you keep thinking what should be better for this particular step. And if you visualize the things before surgery, during the surgery and post-op period, then we can do further. Dr. Abhay, good afternoon. Would you like to make a first presentation? Yeah, because you have to go. Let's Abhay do first. You can go there, sir.
Thank you. I do receive research grant support from Alcon, but there's no relevance on this presentation. And this is a topic which I know Professor Tithial and the team and all of the people sitting here have worked, original work, and suggested so many innovations to us. So I'm really fortunate to be speaking here in front of them. I acknowledge the contribution of Dr. Osher here, from whom I learned a lot. And there are a few pearls, and you can go through these pearls, but all of these little details, it is the details, and if you pay attention to all these little tricks and details, you will be fine at the end of the day, and your heart will not come to your mouths. So, having done that, first is to avoid rapid buildup of hydraulic pressure between the posterior capsule and intraocular lens. Then, therefore, the subcapsular hydrodissection, or also known as a corticocleaving hydrodissection, is out of question. So, do not do that. So, what do you do that? Because you need to create a mechanical cushion effect. So, the wisdom over the years was to create a conventional hydrodelineation where you penetrate the lens substance from the anterior surface from the rexis side and penetrate and inject and create a mechanical cushion. It works very well most of the time. But sometimes, because it really lacks precision, it can go inadvertently into a wrong place, as this animation illustrates. I'm going inside, but at times, if you inject very forcefully, particularly, it can go to subcapsular, and it's the very thing that you want to avoid can happen. So, with the help of our team, we taught this technique, which we presented in 2004, worked very well at the time, and it's still working well, where you create a space in the center before you do any hydro procedure, and then titrate the width of the cushion that you want to create, and therefore penetrate with the right angle cannula into the appropriate depth of the wall of the trench and generate mechanical cushion effect. As this video illustrates, you can have a thin epinucleus or a thick, depending upon the depth that you penetrate. In a typical classical postupellar, it's not difficult, and with one injection you can create, but sometimes you have to go to the other side and so on. And third is any time of the procedure, right from the beginning, before making an incision. Do not make a main incision first. Make a side pore, inject OVD, and then so that there is no forward bulge. So every step of the procedure, including the incision making, you need to be careful. And a classical teaching over the years is to inject OVD, and I would suggest dispersive OVD before you retract the instrument, and use a bimanual technique. Even if you are using a coaxial as a rule, I would recommend bimanual, although the coaxial in the expert's hand will work very well, but bimanual will maintain the contours, and once again, before you swap, inject dispersive viscoelastic and perform that removal very safely. Now, notice the low parameter. This is an old one which shows the irrigation bottle height, but as low as you're comfortable that you want to do, and low flow rate matching that low IOP. Now, this is very important, and we were doing it, and we are doing it, but there was no understanding why we were doing it, and what Osher has described is a derouting or whatever, but essentially you are creating a communication between the front of the epinucleus plate and in the behind. So you detach the epinucleus only partly, do not bring it to the center, and so what has happened is that you're creating a fluid balancing going to the anterior to the posterior, and therefore there won't be any, the risk of the rupture would be reduced. And we find, like Professor Titial, flex technique has an advantage. We described femtodelineation in 2015, and Professor Titial group also described similar, or not similar, but different technique using flex. And whatever technique you find, but flex in general helps us. And somebody showed us how this femtodelineation works. You're creating a cushion after cushion and come to the very last epinucleus at the very end. And this is how it would look. You create a kind of a chop in a central delineated nucleus, and you can shell it out with the chopper and present it to the phaco tip, which remains in the center of the globe, and you can remove it very effectively, that sort of thing there. And then finally, you need to have that communication established between the posterior and anterior compartments for the fluid balancing. And that's the next step you would be able to see, I hope. But present it, all this is so easy because the laser cuts very vertically and smooth cut. It's very easy to insert a chopper or a device where you can present it there. And now I'm creating a space between these, detaching as much as you can. Obviously, you will not be able to do it subincisional, but now you can have an option. You can do a subcapsular dehydration in the subincisional area also with the 90-degree bent cannula, or you can shell it out with the chopper as you did it in the other part. So that doesn't matter what you do. But bimanual, if it is not a very thick epinucleus, also works very well, and you can clean that up to your satisfaction by swapping the instrument, and most of the time you are okay. Now, implantation is something which is nothing unusual if the rupture, the posterior capsule is intact, and you have your, typically it will be a toric lens, or a patient wants the multifocal or that sort of thing. So it's always a deadly combination, and you do not promise that lens up front, always give an option. So we found, we reported 36% incidence way back in 1999. And then we gradually worked out, and with the delineation 3.8% when we reported in 2015, probably it is little less, but it is still not 0%. This is a 49-year-old male, bilateral pre-existing defect. Left eye, white cataract, other one you could see the defect. So we decided to do the first eye with a clearer lens in front with the femtodelineation, and we found, and you can recognize the posterior capsule pre-existing defect there. And so we need to do the same principle, but the aim here is to prevent vitreous prolapse into the anterior chamber area, and the same principle, but lower IOP and lower flow rate. The flow rate would be 16 or 18 or 20 depending upon the comfort, but as low as you're comfortable, and IOP very low. We don't want too much pressure there, although you want to prevent surge or a forward bulge. So on one hand, you want the pressure sitting on it, but have a balance of it. And typically with these flex techniques, it is not that difficult to present the material, and the same principle. And now I'm using a 3-piece IOL here haptics in the sulcus, just behind the iris, in front of the anterior capsule. And then I would like to capture this, and I have an option, anterior capsular axis, which is good with the lens X, and also posterior, the tear. This tear is very strong because it resisted all the maneuvers and until the surgery. So I believe that the zonules are preventing it to go over on the other side of the posterior capsule. So I'm capturing through both anterior capsule and that tear which is in the posterior capsule. Always make sure that there is no vitreous at the end. I had the vitrector out, so I had to use it and justify that. But otherwise, the IOL is captured through both the rexes, and this is how it looked down the line. Always monitor with retinal colleagues and document as much as you can. But this is the other eye. Now we are confident to do the other eye, so we did a flex again, and that's a great thing in a wide cataract. Inside-out technique here. Even if the lens is dense, you try, don't lose your heart. Whatever you can, most of the time you will be able to do it. Obviously, if it is very hard, you won't succeed. But a thin epinucleus plate is enough, and then you do all the manual tricks that you learned, remove with the bimanual, and once again, this lens is removed, no drop. But because I suspected a vitreous loss, I'm doing a vitrectomy, and you have an option of doing limbal vitrectomy, both irrigation and vitrector in the front, and also other option, and I find this is useful, irrigation still in the front, but one port vitrectomy. And our aim is to do a vitrectomy not only in the center portion of the eye, but also behind the area of the optic, so that the IOL is supported very symmetrically. And once again, the procedure is repeated, where we put the lens haptic in the ciliary sulcus and capture through the tear as well as anterior capsule. Because these tears, because they are present for some time, they are fairly strong, so you don't need to worry about it. So I'm just trying to show that the optic is behind the tear as well as the anterior capsule, and then always check it, as I showed you in the early part, and make sure. Now, this is the most important part. Always talk to the patient. Patient is always nice and he understands, but the relatives don't understand. Their spouses, their parents, because they are young people. They are worried about the young persons for obvious reasons. So tell them, bring them back again, the whole family. We have a rule that we do not, when they come for the preoperative workup, which is separate from the OPD, separate time slot, they come with the family and we hammer them. The thing. But remember this, and I keep showing every time this one. We were so happy, all the nurses packed up their trolley, and this is what happened. So posterior polar is not over until it's really over. So thank you so very much for patient hearing, and thank you for readjusting. Thank you.
Over to the next presentation, the role of imaging in cataract surgery. As sir sets up, sir, what's your take on doing hydrodissection in cases in which in OCT you don't feel it's high risk?
Sorry, sir, where you do?
What's your take on doing hydrodissection in a subset of cases of posterior polar in which you feel like
You can
the
do it.
posterior capsule is not that involved?
Yeah, but I'm a coward. I'm very timid. Once I know it's posterior polar, and I know in my heart that I'm not going to rupture because there are observers coming to see, but I will follow the principle. It's a discipline. I mean, I'm sure you can do it, and you can make a 6 or a 4 sometimes, but not everybody's Shivam Dubey. Okay.
Having the FEM2. Myself is a very poor. I have no Sukhaya or Mirage. But I have the Centurion gold machines. How can I manage the PC? It is mandatory to have the FEM2 to tackle the, only 3%, you have told it 3%. 3%. Now, yesterday I have.
but you need a machine with a retractor capability, which you all have. All the machines have now. So
Another, just one question, what is the cortical separation, mechanical cortical separation in the PP cataract management?
mechanical separation.
Mechanical cortical separation, yep.
I've not done it, but if you are doing it, carry on. Thank you.
Thank you, Abhay, for a wonderful presentation. As usual, he's been a teacher to all of us across the world, you know. I'm going to go a little backwards now, as I started in the beginning. And if you see things clearly, before surgery, during the surgery, and post-op, you can manage things very, very comfortably. And this is what I'm going to talk about today. Examination. A patient examination, not only the eyes, entirety is also very important. What are the drugs patient is taking also very important to decrease the complications happening. A good slit-lamp examination for a white cataract is very, very important to see the bulge in the anterior capsule, the shallowness of anterior chamber, the intralenticular clefts. These are all visible if you see very, very carefully in a high magnification, and that tells you which type of patient you are dealing with. But nothing better than capturing them in a OCT. If you have anti-segment OCT, that gives you a picture which you can see comfortably and assess your patient appropriately and plan your surgery subsequently. The devices which can give you access to these picturization is, anti-segment OCT, as I talked about. You can have various other devices like intraoperative OCT microscopes to give you intraop OCT picturization. If you have a femtosecond laser devices, they all have a OCT, and that can also give you the morphological feature of these cataracts also. So this is what our publication came in the IGO, which has a very nice citation, the intraop optical coherence tomography during the surgery, and which tells you that it's not only for a cataract surgery, it can be useful for a cornea surgeries, it can be useful for a refractive procedures. Name any surgery, this OCT is going to be the future. All microscopes, in fact, should have these OCT attached with a better quality for future also. Let's see white cataracts, which you all know is the challenging cases for all of us. We don't know which type of white cataract is going to give which type of problem to you. And mainly, there's an absence of red reflex, there's a query, raised interlenticular pressure, and the lack of epinuclear cushion during your phaco also. So this is what we picturize in the series of white cataracts with the help of Dr. Manpreet. So this we divide into 4 types of white cataract. There are not only 4 types. You can have in between types also. There can be multiple types. But classically, we could divide into 4 types: type 1, type 2, type 3, type 4, based on 2 parameters. One is without intervening. So if you see, this is an OCT picturization. We look for a convexity, the arrangements of lamellae, interlenticular clefts. Based on that, you can divide. Second is, once you open the anterior chamber, you inject a viscoelastic. What is the feature of anterior capsule after injecting viscoelastic? What happens? Is there a pocket? Is there a definite flattening? If there's a shift of fluid happening, the dynamics of initial nick of a capsular axis, what happens there? Is there an immediate release of fluid? It is a turbid fluid, no release. And what happens to the pressure inside the eye? Does the entire space remains clear, or it gets turbid because of a fluid release in these cases? Is one very important aspect. If you see this picture, type 1, where you have very homogeneous appearance, regular arrangement, there are no clefts. So this particular white cataract doesn't have a fluid inside. There's no raised interlenticular pressure. If you make a nick also, nothing happens, nothing is disrupted. You can do a routine phaco in these cases. So this you can pick up, not only because of OCT, you can pick up an slit-lamp examination also, no fluid, no raised convexity there. You can do routine surgery for these patients. This is the type 2 variety. If you see here, you have not much of convexity to be seen, but how thick hydrated cortex fibers are there all around, right from the center to periphery to the entire length of a lens. And all the clefts are underneath these hydrated fibers. So even if you make a nick, nothing is going to happen. These fibers are going to bulge out because the pressure is underneath these fibers. So this type of white cataract is the one which is the challenge for our rexes going to periphery and difficult to control sometimes. So you can see here, I was trying to do a 1 millimeter rexis here. You can see there's a tendency for it to go to posteriorly. And see how in the video here, this is the same appearance here. I make a nick here. This mountain of cortical fibers coming up, no release of pressure. So these cases are one where you have a lot of challenge happening. And once you inject little bit of dispersive viscoelastic to flatten that, I'll make a small opening, take out the dehydrated cortical fibers. The convexity will become concavity now. The pressure is not there. You can do a nice capsulorhexis. This type of case we feel may not be amenable to needle aspiration because it's the cortex which is hydrated. If you would have fluid, needle aspiration does help in these cases, in a type 3 variety of cases, where you have a little bit of cortex which is broken, there's a fluid, there will be release of a oily type of fluid coming from here, pressure goes down. Needle aspiration is very helpful in these type of cases to decrease the pressure and continue the surgery also. Type 4 is the one you have total milky fluid because all the cortical fibers has become fluid in these cases. As soon as you make a nick, entire milk comes out, the chamber becomes deeper. Sometimes rhexis become very difficult. It's a long-standing case like a Morganian cataract. There you may have to refill the anterior chamber with viscoelastic to maintain the pressure from behind or from above the anterior capsule in these cases also. Femtosecond laser also is, can be appreciated very, very effectively in these cases also. You can see this is the picture here. Once you go to the picturization of the lens here, you can see thick hydrated fibers, fluid orientation. So this is a type 3 or type 4 type of white cataract, where I'm pretty sure there will be release of fluid with a gust. You can see here. And there's a pressurized thing. The best thing in a femtosecond laser is everything's happening in a closed chamber. There's hardly any chance for extension happening in these cases also. After you apply the laser, you have to be very careful because you're not seeing anything. The staining is very important. You can see the hydrated cortical fiber still there despite the release here. So you should be a little careful. Make sure your capsular opening is done in a very effective manner, like you do for a routine capsulorhexis. Same thing, same manipulation can be done here so that whatever tags you have, they don't go to periphery and you complete the rhexis in these cases also. So this classification tells you how to go with these cases. As I said, type 2, where you have thick fibers, the needle aspiration doesn't help in these cases also. Type 3, type 4, the raised ILP goes down as you aspirate the fluid in these cases also. Luckily, the type 2 variety is very less. Around 6% are type 2 variety amongst all white cataracts. The rest you can manage very effectively in these cases also. The learning which I got from this was to, if you have an anti-segment OCT with you, do OCT for all your cataract patients. Let it be white, let it be subluxated, you should do, because they can pick up various things. In my subluxation cases, sometimes miss the vitreous in the anterior chamber. OCT gives a nice pixelization there. And always, if you have access to IOCT microscope, why not to use that and have a best outcome coming. Little bit of posterior polar cataract, because imaging there is a very, very important also. And various types of presentation are there where you don't know which type of cataract will have weak posterior capsule or adherence to a posterior part of a lens, or they may be open capsule in these cases also. Both anti-segment OCT and OCT integrated microscope will give this picture. This is a beautiful presentation by my younger colleague, Dr. Amar Pujari, where we assessed the 100 consecutive cases of posterior polar cataracts. There we found 3 classical appearances in anti-segment OCT, which are high-risk cases. A conical shape you can see here, and this is a moth-eaten appearance where you can't see clearly what is the definition of posterior capsule here, and eclectic variety. Why these 3 morphologies are important? If you have these morphology, which is there in around 10% of cases, and there the chances of posterior capsule opening is almost 100 to 60%. So this is important. If you picturize these type of shapes, you should be very careful, which Dr. Abhay talked about. Don't do hydrodissection in these cases. And rest 90% of cases are posterior polar type of cataracts most of the time. Dr. Manpreet talked about that. We also looked into these aspects, intra-op OCT also. There we always look for integrity of visibility of posterior capsule. If you can visualize the posterior capsule clearly in the OCT picturization, then your surgery becomes very simple like normal surgery in these cases. But difficulty is there where you can't visualize the posterior capsule behind the posterior polar disc. Then these cases you have to be very, very careful, do only hydrodelineation and don't do hydrodissection like this. You can see this is the delineation which has happened. Decompress always. This was the delineation. and subsequently decompression, see the fluid has come out. Never let fluid to be there, otherwise this will extend during your phaco, and PC can open up that time also. The harder cataract is a major challenge in these cases where you have, moth-eaten appearance and things can be difficult. There we describe this chop and tumble nucleotomy technique where you can do a very effective emulsification in a posterior polar cataracts. And this imaging intraop is a wonderful way to see that you have created the cushion which you require. This is a thick epicortical cushion safeguarding the posterior polar cataract, which has to be done in these cases. You can see this chop here, Dr. Abey's, you can say the explanation where the internal hydrodelineation happened once you take out a piece of a nucleus. The fluid shifts into the core of a nucleus and epicortical cushion, and surgery becomes simpler subsequently also. I can just tumble this nucleus without rotation and complete my phacois. So this procedure totally avoids the rotation or any disturbance to epicortical cushion, which is so important for all these cases as such. Femtosecond, again, I'm showing here. This gives a clear OCT picturization that what type of posterior polar cataract you have and how do you manage these cases also. Sometimes this picturization imaging also important for difficult cases where your incision may be a challenge. So this is one of my patient with a Fuchs endothelial dystrophy. I completed phaco in this patient, and towards the end I was doing hydration of my own. I realized there's some, I could see membrane here. The OCT told me that there's a large, detachment happening in that area. If I would have missed this, next day there could be a white cornea in a Fuchs patient that I had to do. You can see how big is the neuron detachment there. So OCT picturization on the table is safeguarding us. Put a bubble like a DMEX surgery, put it there for 3 to 5 minutes, and entire thing is attached. And you are quite safe. I would summarize that it is useful for cornea surgeries, useful for cataract surgeries, phakic IOLs, vitreoretinal surgery, and all challenging cataract cases. The picturization imaging of cataracts is one way to go for decreasing your complication, maybe improving your surgical acumen also. Thank you for kind listening.
Wonderful overview of the role of imaging in cataract surgery. We now have Dr. Suven Bhattacharjee who will take us through phacoemulsification in small pupil.
Thank you very much, Professor Titial, sir, for this very kind invitation and this very popular course. So I'll be talking on phacoemulsification in small pupil. It's all about anticipation, identification, and management. I do have a financial interest in the BHEX and BOCTA by virtue of my ownership in Melinman devices. Now, here is a scenario. It's a 6.5 millimeter pupil. Is it a small pupil? Would you use a pupil expansion device over here? Now let me give it a twist. 55-year-old patient, hypertensive, on antihypertensive drugs, diabetes mellitus, grade 4 mature intumescent cataract. Let's add some more spice. 10 days back he had a surgery, had intraopmyosis, IFIS, I had a tough time, I had used a BX. The BX kept disengaging because of the pupil size fluctuations. So what are my fears over here? What if there is an intraopmyosis and the capsular rhexis starts running out? I have a capsular rhexis tear, or I have a PC tear. So I chose to use a BOCTA because of the experience that I had in the previous surgery. Now, BOCTA is a variant of the BHEX and gives a much wider pupil expansion. So, and this is something, look at the fluid cortex. You can see the pools moving around. It's like lakes over there. I'm trying to break the lockley and watch this. Yeah, that gush of fluid, that is basically, if I had not done that massage, I would have probably had a locule and this capsular rhexis would have run. And now this is a thick, leathery cataract over there. And I'm so happy that I have such a wide pupil to see and safely do the surgery. Rest of the surgery was okay. So now this is another scenario. Thanks to Dr. Saurabh Patwardhan, intraopmyosis, suprahard cataract. What do you want now? You want a pupil expansion which is really wide because you want to see the capsular rhexis, you want to deal with this hard nut and have a safe surgery. So unless you have sufficient pupil expansion in a situation like this, you are really inviting trouble, and the time you save in not using a device will probably be counterproductive, and you'll end up most time managing complications. So small pupil is a relative term. Depends on the conditions, the circumstances. Now, why would small pupil be such a buzzword, and why is it so important? When the pupil size drops from 8 millimeters to 4 millimeters, the pupil area available is not dropped to half, it drops to quarter for the surgeon. So that leads to vision-threatening complications. Now, can we predict the pupil, which pupil size would land up in IFIS? Unfortunately, no. Even a 7 millimeter pupil can land up in IFIS. So, the current definition of small pupil based on literature is 6 millimeters. 4, 5 is something which we have talked in the past, and 6 millimeters intraopmyosis or small pupil is defined as 6 millimeters. This is a book, so it's all about decision making. This is a book, one of the first chapters in a book that I'll be writing. So this will be released probably in a couple of weeks. So here we are talking about decision making. And this is a very important part of the chapter. This is a flow diagram or an algorithm. Now what I've done is I've classified small pupils below 5 millimeters, small pupils 5 to 6 millimeters, and intraopmyosis to less than equal to 6 millimeters. When you have small pupils less than 5 millimeters, you must be thinking of a device. You could differentiate whether it's an elastic pupil or a rigid pupil and choose to use a kind of device, whatever you want. If it's a small pupil which is 5 to 6 millimeters, you need to classify if these are high-risk ones, high-difficulty ones, or exacting visual expectation types. These are the ones which are, need to be handled with care. If it's a low-risk one with low risk of intraopmyosis, you can choose to use an intracameral mydriatic. If the pupil enlarges, fair and well. If it doesn't, there's progressive masses, use a device. But for the high risk, high difficulty, and exacting visual expectations, there is no second thought. You straight away go ahead and use a device because you want a safe surgery. Fortunately enough, surgeons have lowered the threshold because of the same reasons, because of exacting premium lenses that we are using. Now you need to know your patient. Like we say KYC, I say KYP. Systemic diseases have a huge influence. Hypertension, it's not the hypertension actually, it's the drugs used in hypertension are alpha blockers. That's where the problem is. We found that hypertension has an association with small people. IFIS, no. Intraopmyosis, diabetes is a significant cause of intraopmyosis. We tend to overlook that. It is a very common cause. And then there is a host of conditions and disease. Parkinson's disease is strong. Now we have this presbyopia correction myotics, which are going to be a pain after a few years. You are going to have poor mydriasis in these cases. And there's a host of drugs like we know, tamsulosin, psychiatric medications, antidepressants, antipsychotics. In women, brinzolamide and salbutamol strangely have a disproportionately high in IFIS. There's a lovely paper in AJO in 2025. So no amount of history taking is going to help you prevent surprises. Pharmacological agents, yes, there are a lot of them, and maybe that would be a first line if you think that it's a low risk and you can go by, but it's not fail-safe. The people can still come down. NSAIDs. Do not be under the misconception that they augment dilatation. No. They just prevent intraopmyosis caused by prostaglandin release by manipulations of vicotouch of the iris or nuclear fragments. So it doesn't augment. So if you really are going to have a clean surgery, you don't need NSAID, but in patients where you have likelihood of intraopmyosis like a diabetic, better to start for various reasons that NSAID that you start pre-op helps you, even for the CME. Small pupils need to be classified into two types, very clearly, elastic or rigid. Elastic is like a rubber band, and you could use any device. If it's an intraoperative myosis which comes down, it is an elastic pupil. But the rigid one is like a string. You need to tear it. There is no way it's going to expand. So you have to make it favorable for expansion. Depends upon how rigid it is. So you can choose either a rigid device like a bulky device, or you can use a BHEX or things like that. So it depends upon your personal choice. You can determine the elasticity of the pupil before you start the surgery. As soon as you made the paracentesis, inject a little bit of BSS or ringolactate, whatever you use, and inflate the anterior chamber. If it momentarily expands, it is an elastic pupil. If it doesn't budge, it is a rigid pupil. You need to use two Coughlin hooks and probably stretch it, or if you want to use a bulkier device and make it more favorable for expansion, and then you can use whatever device. Even if you use iris hooks, I would recommend that you use a little bit of stretch before that, then you have a better looking pupil the next day. So mechanical dilatation of pupil, we've already talked about that. There are various options that we have. Where do you inject viscoelastic? under the pupil margin. When you're using a device, keep the anterior chamber shallow, let the iris bow a little anteriorly. That helps you even using your iris hooks. I'll not talk about iris hooks and retractors. I think all of you can do that very well. The downside of the iris hooks, not that I'm discrediting it, I have used a lot of them. I've been involved in the development of them also. But then there's a lot of corner space which is underutilized or rather unutilized, and we don't need it. And that causes a little stretch over there. The whole iris is really elevated to the limbal plane, and it comes in the way of your phaco probe and instrument, especially in a shallow AC. It can be a little bit of touch and go. This is a published study where it says that the iris hooks take more time. Maybe in Indian scenarios, probably less time. You never know. And it can leave marks. So there came the BX pupil expander, the uniplanar device, which was very different from all others, very thin, and had notches and flanges, does not require an injector, and it bends, iris bends along the notches. And this is the whole armamentarium that we have now. The BX 2.0 is slightly larger than the BX and slightly thicker. It works for elastic and rigid pupils. So maybe it's a good device to keep if you want to keep one. This is a regular 1.8 to 2.2, but it goes in very easily through even a 1.5 incision. In the same way, I'm showing inject viscoelastic under the pupil margin. Simple steps. Engage the notches, tuck the flanges to engage the notches. That's the first flange. The second, alternate flanges go under the pupil, and you have a hexagonal pupil. And rest is all very easy. It doesn't come in the way of your cortical aspiration, and you can do IOL implantation. And removal is very, very simple, probably the simplest device to remove, even easier than iris hooks. And it can be removed through a side port. 0.9 mm side port. It's 0.075 millimeters, thinner than a hair, and you can just grab the flange with your BX forceps, advance it centrally little, disengage the two notches, and it just literally walks out of the side port. The B-Octa is a newer device, and it's a large device meant for SICS as well as phaco, provides almost a 7.25 to 7.5 millimeter pupil. So that is a huge expansion. I'll just finish briefly, and that's the nucleus being prolapsed into the anterior chamber. Though this is on phaco in small people, a little bit of SICS over here. And as for phaco, well, yes, you can definitely, I showed you a few, so I'll skip that. IFIS, till now I would say that we really didn't have a device. Severity depends on the iris prolapse depends on the severity of the IFIS and the pathological damage. But users have found that the B-Octa does have a low role in reducing floppiness of the iris and restricts iris prolapse. This is the go-to usage chart. So if you're a star beginner, maybe BHEX, but all the three can be used for phaco. For SICs, it's B-Octa only. And this is a hard cataract. I think these are videos. Intraop meiosis. You inject viscoelastic under the iris and over the capsular rim to create that space again so that you do not engage the capsular rhexis margin. And this is probably the last video that I'll show. And this is Deepak Megur's video. And now once this is happening, you need to now really actually inject and that. Inject viscoelastic under, create that little space, and then you start tucking the device, and you have a well-expanded pupil for surgery. We'll skip this, and skip this. And now, choice of pupil expander in intraop meiosis could be a iris hooks or a BHEX or a B-Octa or Mulligan, whatever you choose. But if you have a subluxated cataract, I'd always go for iris hooks. There is no. Always remember, for small people, I always say this should be a take-home message. If you are undergoing cataract surgery and have a 4 millimeter pupil, what would you prefer your surgeon to do? Use the device or be heroic? We discuss a lot in this group. If you're interested, I'll be happy to get you in. And we discuss only small people and anything under the sun about small people. Thank you very much for this opportunity, sir.
Thank you, Dr. Suvain, for a wonderful presentation. I think one thing which has been there for some years now, please have a seat, like the BHES rings has given a new incentive for people to use this device because it is very simplified, very easy, and the techniques which people have put in the various videos in their YouTube has make things very simple for people to learn also. And request Namrata to put up her presentation in the meantime. And the new thing which is coming, the Octa, which has made a huge difference for a people of SICS also. There also you require a pupil expander sometimes. I've seen, I have done sometimes also with the hooks because the pupil is so small with such a large nucleus. And this B-Octa is going to be a real game changer there. And you can see the various videos there, learn how to do it so that you have a least problem in these. Access, very simple to do access. Thank you, Subin, for this wonderful innovation and Make in India project.
Thank you, sir.
Dr. Namrata, we have now the Chairman Scientific Committee and one of the best scientific person the world has, and huge inventions, publications, teaching, research, name anything. She's one of the top women in the world.
Thank you, sir.
Okay, she's going to take us the one of the difficult part to do phaco in all these corneal problems, which she is expert. Dr. Namrata, please.
Thank you, sir. And I have no financial or proprietary interests. And always, I think, as cataract surgeons or as general ophthalmologist, you would want to know where you would do cataract surgery alone or you would combine it with a corneal transplant. And basically, if you're well versed with SICS, it is good to do that. But we all began learning ECCIOL and went straight over to phaco. So I try to do phaco alone rather than SICS in these cases. And the factors which determine whether you will do a single stage or combined procedure depends on the type of the corneal opacity of the haze, the location of the haze, the expertise of the surgeon, the availability of the donor corneas and visual requirement and risk-benefit analysis, and sometimes also the patient's own willingness as to whether the patient wants to undergo a corneal transplant or not. So, like I say always, that this one half of the cornea should be clear. So you can actually do phaco through the half of the clear cornea because you can see all the maneuvers and everything that is hiding underneath can be pushed here into the area of visualization. But this can be only done if the opacity is peripheral or paracentral, and if it is central, then it cannot be done because then it has to be combined with a corneal transplantation procedure, or if it is very superficial, then PTK or ALTK with phaco or DSEC-DMEC triple, depending upon whether endothelium is involved, and all layers, if PKP triple, all layers of the cornea are involved. In these cases, generally the intraocular lens is monofocal. We are trying to see whether EDOF or monofocal plus would make a difference or not in a study that we are conducting. Keratometry is often not possible, so I like to take a standard K. You can alternatively calculate it with the surgeon factor as well. Biometry is again often not possible. Biometry is done in these cases, but IOL master is often not possible in these cases because of the visualization, which cannot be done. Now, word about this Fuchs dystrophy with cataract, because there will always be a question, what will you do in such cases? So I go by this, that is, if there's poor view for visualization and for doing phaco, and if the CCT is more than 650, cells are less than 800, then we would combine it with a corneal transplant straight away. But if the view is clear and if the cells are less than 650, cells are less than 800, CCT is less than 650, then we can counsel the patient, do phaco, and then see whether the patient requires endothelial keratoplasty or not. And if there are no epithelial changes and the cells are good, the CCT is also okay, then you can do phaco alone. So here you will plan your incision. So first thing, before you sit on the microscope, you see which side the incision has to be made. So for instance, if it is like this, then temporal incision is better. But if it is like this and this is the head end, then superior incision is better. Again, to show this case of corneal opacity, but here it is not that difficult because the opacity is bang on and it is a leukomatous opacity. There's hardly any scattering which is there from the peripheral part. And when this occurs, then actually what you need to do is just initiate your access from the area which is relatively clear. In the clear part of it, you can do phaco as you would do normally. And as you come to the part where the haze is present, then again, like I said, everything has to be brought into the area of visualization. So keep lollipopping the fragments of the nucleus or the cortical matter with the help of the second instrument into your phaco probe or into your eye irrigation aspiration probe. And once the cortical aspiration is done, always and almost always, you put the intraocular lens and everything will appear a lot more brighter than what it was before because the refractive error gets neutralized. Again, this case was a one-eyed patient, didn't want to go a corneal transplantation, but this case highlights all the things that you should undertake. For instance, here, this is the temporal incision. This half of the cornea is clear. Then stain with trypan blue dye, and then push the globe a little bit to see the edge of the rexus there. And when you come in this area of the haze, then go in one go. Now, there's an optical iridectomy there, so eccentric rexus and eccentric crater. And when you do eccentric crater, always remember to put your retroillumination on, because when you put your retroillumination on and do phaco in situ, that means you phaco and you eat, you phaco and you eat. So as the red reflex gets better and better, you will be able to see better the grayish and the whitish nuclear fragments. And then again, the second instrument plays a very important role here whenever the corneal opacity is there, because everything that is underneath this has to be brought to the area of visualization. And then sometimes, like I said, when you start to put the lens, you can actually see the edge of the rexus there, and then place the lens inside as well. With the Care Group company now, we are working also with the intraocular lens with asymmetric haptics, because especially in optical iridectomy cases where you don't plan corneal transplants. Very much similar to the case that I showed earlier. Only thing is, now here you have to put nylon hooks here to expand your area of visualization, and again follow the same principles. Temporal here, this half is clear, so you can do your eccentric rexus. Eccentric here, it was central rexus which was done, but eccentric phaco can be done from this area of visualization. Now, this is yet another technique. What keeps happening is that when there's haze present, you try to phaco here in the center, and the nucleus keeps springing up and keeps coming inside, doesn't allow you to chop. So what you do is you do these peripheral chops first, so the nucleus is no longer taut, and it kind of breaks down. This is just to show the case like this. So what is basically done is that after doing rexus, give peripheral chops. So when you give those peripheral chops, it will not keep springing up into the capsular bag, and it will kind of get paralyzed, and then one of these wedges can be removed, and then the rest of the wedges will follow. So this is a small trick just to see that your cataract doesn't keep coming up and impede your chopping maneuver. Now, this is a black and a white cataract. Black because it is tattooed, and white because there's a corneal opacity. Again, notice that you have to expand your area of visualization, nylon hooks, then you have to use dispersive viscoelastic agent, then you have to do rexus. Don't leave the edge of the rexus here. Here, the edge of the rexus was lost, but we could pick it up through the intraop OCT microscope. And then the same thing, phaco in situ, so you keep getting the red glow to become better and better by keep eating the nuclear fragments. And then notice that this is so much better as compared to what we started with. And once you put intraocular, once you put the IOL, then it becomes again a lot better. And then I do what is called as the pilocarpine test. So what I would do is I would put pilocarpine to see where it is constricting, and if I need to, then I would even do a sphincterotomy or expand the area of visualization if required. We did publish this new surgical approach in Steven Johnson cases, and this I'm showing because these are high-risk grafts. And here again, temporal incision, nylon hooks, endoilluminator inside the eye to see where you are chopping, because that helps you to brilliantly see it. And now endoilluminator outside the eye to see where actually the lens is going, and then these nylon hooks can be removed. If you do corneal transplants for SJs, then they're sure to fail. So this is the post-operative result with good results. I'm not saying an eagle's eye vision, but for the patient to become functional and for the patient to actually do his or her daily activities. Again, this is a case where pannus was there, and we removed the pannus, and sometimes you can be really surprised, and like I always say, that eye is over there and you have to dig it out. So you dig out the eye from here, so remove the entire pannus bit by bit, tease every fragment. It is it requires a lot of patience. And then here chandelier has been put, and once you put a chandelier, you're completely in a different world of visualization, different world of also doing surgery. Because when you do surgery, it feels differently. And then subsequently, now because it has become a lot clear, so you can shuttle between the chandelier and the normal operating microscope light, and rexus is being done here, which can be very clearly seen. Then once you put the chandelier on, everything brightly illuminates. Otherwise, it becomes difficult to see. So phacoemulsification is done, irrigation aspiration is done, intraocular lens is implanted in the bag, and I also inside the bag. And then just to show the pre and the post-op picture. Sometimes, like I say, you have to dig it out from to see where the patient can see from, because the patient hops from surgeon to surgeon, but if nobody does a case in these eyes like this, then we will not be able to give vision to the patient. Then femtocataract and corneal haze, and I'll just show this last video to show, I think it has a huge role to play. It is fill in the blanks. So it'll cut some places and not cut some places, but that doesn't matter. So you have to fill in the blanks. Rexis is not here, so you just fill it up. CHOP is not here, so you just do it manually by rotating it. I think, again, it has an important role to play, and it works well. Again, this paper is already accepted in JCRS to be published. This I will skip because this is beyond the control of the cataract surgeon alone and requires corneal transplantation. But the algorithm that we have come with and we have published in JCRS as a review article, cataract surgery with corneal opacity, you can do phaco alone or with optical iridectomy or even PTK with phaco. And depending upon where the opacity is and if it is central, then SALC triple, ALTK triple, DALC triple, DSEC DMEC triple or PKP triple, and this is published in JCRS as a review article. So to conclude, in high-risk cases, do phacoemulsification first, but those for good prognosis, do combined procedures, and always explain to the patient that ambulatory visual acuity is what we are looking at. And thank you very much for your kind attention.
Thank you, ma'am. We now move on to phacoemulsification in soft cataract by Dr. Tushya Omprakash.
I think now we can, I just put one query to both of you, Manpreet and Namrata. Like, there's a lot of time we have a keratoconus patient with cataract, and difficult to really do a biometry correctly or the keratometry correctly in the patient. What should be our way to look into that?
One would be keratometry by different devices, and if it's a mild to moderate keratoconus, then you can take whatever you get in the newer IL pass, go for pentacam, the equivalent K readings, or the optical biometry captured keratometry. If it is an advanced keratoconus with K of more than 55 diopters, it has been advised in literature as well to take a standard K of 43.5.
Okay, Tushya.
First of all, I would like to thank Dr. Tityal sir for giving me this opportunity. So I have no financial disclosure. So we all know that there are quite many challenges in doing a phacoemulsification in an ultra soft cataract. You can end up into a crater, it is difficult to divide, then you have a lot of corticocapsular adhesions, you're not able to rotate. So we came out with this technique a few years back. It's called the rapid technique for ultra soft phacoemulsification. So the prerequisites for rapid en masse removal of soft cataract is that the age should be less than 50 years. The grade of cataract should be either a clear lens, a mild PSC without minimal nuclear sclerosis, a developmental cataract. A good size 5 millimeter, 5.5 millimeter CCC is essential. And cortical cleaving hydrodissection is important. We don't do any hydrodelineation in this case. So what is this technique about? So if you see, you have to remember the acronym RAPID. So R stands for rotation. So you have to do multiple point hydrodissection so that you break down all the corticocapsular adhesions, and with the Sinskey or a blunt chopper at the peripheral rim, you can rotate it. Second is alignment of phaco tip sideways so that you have a coordinated assistance with the second hand instrument while you're doing phaco. Then placement of the tip at the nuchal rim, and then impaling in full aspiration mode, and then devouring of the nucleus or emulsification of the nucleus. So in this graphical animation, you are doing rotation, alignment of the tip sideways, placement of the tip at the peripheral rim, impaling and devouring or emulsification of the nucleus. So if you see here, so you need a good 5.5 to 5.5 millimeter rexis. That's an important prerequisite for it. And then you do a multiple point hydrodissection at different points so that you break down all the corticocapsular adhesions. And once it is broken, the second hand instrument helps in rotating the nucleus, and then alignment A of the tip sideways towards the second hand instrument, placement of the tip at the nuclear rim, impaling and devouring or emulsification at the level of iris plane away from the posterior capsule. The phaco tip remains at the safe zone and you're able to complete the emulsification. So this is another case where a white 20% cataract, 30-year-old, and we are very thankful to Dr. Titial for the classification that he mentioned. It gives you a very good preoperative surgical plan. So we start the case. So we do a modified 30 gauge trypan blue staining technique. So what we do is 30 gauge needle under air, the trypan blue is injected. It gives you a very good uniform capsular staining, consistent capsular staining, and then a side port calibrated. So with the same 30 gauge needle, I pierce the central area and simultaneously aspiration of the lenticular fluid at that area so that it becomes a decompressed area in the central zone. And then you make a small baby rhexis, and once you make that rhexis in the decompressed part, and then you do, as described by Professor Chi, capsule milking, where the lenticular fluid from the mid-periphery and the peripheral region is brought out in the center and being aspirated. And with the 25 needle, I go in, take out the remaining fluid, aspirate it, and then followed by a nick. And then you can see that the area is decompressed in the mid-periphery and the peripheral part. Always inject the viscoelastic, not on the other side of the flap, and then rhexis just behaves like a normal rhexis, but I still try to make a smaller rhexis as compared to a normal 5 to 5.5 millimeter rhexis. So these cases this was very soft cataract, so I realized it at this point. So I don't do hydrodissection in any of white intumescent cataracts where I don't know the status of the posterior capsule. So here I realized that it was very soft, so what I'll do is I'll use the escape route which Dr. Bob Osher has described and Abhay Vasavra also told in the morning. And so what I do is, you can see the escape route. What is that? So basically, we aspirate the 6 o'clock area, the nucleus epinucleus mass, so that you have an escape route of fluid can escape from there and it can mobilize the nucleus, and you can easily take out the nucleus without rotating, without doing hydrodissection. It simulates hydrodissection. So what I did here, aspirated the opposite end, the fluid escaped from there, mobilized the nucleus, then I did my rapid, that is, rotation was easily possible, alignment, then placement of the tip at the nuclear rim, and then took out the nucleus mass. And easily you can complete the case without any worry. So this technique of trypan blue staining was published by us. It gives you a very good uniform consistent capsular staining. So coming to the last case, this was a phaco and soft posterior polar cataract, a 35-year-old case, very soft cataract with an open posterior capsular defect. So Dr. Titial and his colleagues have described a very good classification which he already mentioned. So this was an open posterior capsule, pre-existing one. So we have to realize before proceeding with the case that posterior capsule rupture and vitreous prolapse are two different events. So what happens is, whenever you have a posterior capsule rupture, after that you have an anterior hyaloid phase, and then it leads to vitreous prolapse. So my aim here is, whenever you have a pre-existing PCR, I have to maintain the anterior hyaloid phase integrity. So how do I do that? So Dr. Vasavra et al. Have shown that even in an intact posterior capsule, if you're using very high fluidics, it can lead to an anterior hyaloid phase rupture. So my aim here is to maintain it by using anterior hyaloid phase friendly maneuvers. What are those? Maintaining a stable chamber setting, avoiding sudden withdrawal of instruments to prevent chamber collapse, using low IOP settings, slow motion phaco as being described by Bob Osher, low vacuum and flow rate to reduce any turbulence, mobilizing nuclear fragments gently without rotating the nucleus at any stage to avoid further stress on the pre-existing capsular defect. So other important things are, use a calibrated side port as well as a main port incision. It gives you, there's no leakage, it gives you very good chamber stability. Then use active fluidics. I don't have any financial disclosure, but it gives you a very good chamber stability. Slow motion phaco is one more thing which you have to follow. And the aim here is to have a minimal pressure difference between the interior and posterior segment so that there is no pushing back of the nucleus fragments leading to any disruption of the hyaloid phase resulting into a nucleus drop. So this use of narrow calibrated side port technique was being published by us few year back. It gives you a very good chamber stability. So what is my surgical approach in this case? So first of all, use of low parameters. The site of incision would be perpendicular to the site of tear. Why? Because to prevent any further stress on the open posterior capsule. Then I'll be using OVD, gentle OVD without any overinflation of the chamber. Small rexes and oval rexes, as being described by Dr. Kiran, it gives you an advantage of both small and large arm of rexes. I would not be doing any hydro procedures. I'll be using escape route to my advantage and also visco dissection. So let's see in this case how I managed. So incision was given perpendicular to the open defect, slow inflation of chamber with the viscodispersive, calibrated side port incision, a small rexus so that I can plan an optic capture if needed later on. And then as I realized that it was very soft, so I started emulsifying the nucleus and epinucleus mass, and I realized that I should take the advantage of the escape route. So the nucleus epinucleus mass at the 6 o'clock position was aspirated, so the fluid escaped without causing any pressure over the open posterior capsule. Visco dissection was also done, which further released the corticocapsular adhesions. So once these adhesions were broken, I thought that the nucleus was very soft, so I took my IA probe, and with the IA probe, I was able to dislodge all the epinucleus nucleus mass, and once it was fully dislodged, the aim here is with using low IOP, there is minimal pressure difference between the interior and posterior segment. So these nuclear and epinucleus mass, it just floats in the interior chamber without getting pushed back. There is no undue deepening of the interior chamber, no posterior bulging or any chances of extension of posterior capsule defect. So what would I do next? I would definitely continue because I would be using flutter sign, which we published to my advantage. So it is a real-time indicator of anterior hyaloid phase integrity. If you see in this animation, you can see that just focus on the posterior capsular tear edges. They are fluttering and sharp. So this means that the anterior hyaloid phase is intact. You can see that the fluid, it escapes and it comes back, which leads to the flutter of the posterior capsular tear edges. So it gives me a 100% assurance that it is intact. So what if you have a how would you come to know that it has ruptured? These edges would stop fluttering, they become scalloped, and you can see a vitreous prolapse. So if you see in this case, you can see the posterior capsular tear edges, they are fluttering and they are sharp, so this means that the anterior hyaloid phase is intact. So I'm using my low IOP, slow motion phaco. I have retracted the sleeve of the IA tip, so this gives you a different level of irrigation and aspiration, simulating a bimanual IA, and slowly, gradually, I'm able to take out the cortical matter. And now I would be placing the IOL in the bag because as what I'm going to do is I'm going to round off the rexes. I usually do it through the side port so that I can maintain chamber settings and I'm able to see the edges. So I try to complete the posterior capsular rexes. So once the posterior capsular rexes is completed, I try to place the IOL in the bag. So what you can do is you can place the IOL above the iris, and then with the Sinskey hook, you can just nudge the haptic inside the, you can also place a toric IOL if you have a 10 or 20 degree axis placement, and triamcinolone confirms absence of vitreous, and the case was completed. Thank you so much.
Thank you, Tushar, to the wonderful, videos and instructions how to manage soft cataract, and that too in difficult situations. Thank you again. Now we invite Dr. Dr. Rajesh Sinha, who is the professor in RP Center, a wonderful surgeon and academician. He is the current president of Delhi Ophthalmological Society. Please, Dr. Rajesh.
Thank you, Professor Tityal sir, for having me in this course. I'll be talking about managing subluxated cataract and hard cataract. I have no financial interest. As we know, this is the general rule, less than 4 clock hours, you can use an endocapsular ring. 5 to 7 clock hours, you can do a bag fixation by Sione's ring or by a segment. And then more than 7, 8 clock hours, then you have to remove the whole lens and do a scleral fixation of IOL. When in case there is a subluxation or zonular damage, then in that case, there are certain modifications that you need to do. As far as anesthesia is concerned, it's better to do it under the block. Avoid ocular massage. Always maintain anterior chamber. Otherwise, whenever there is shallowing of anterior chamber, there is loss of zonules. If there's vitreous in anterior chamber, do a vitrectomy before initiating any other procedure. Slow motion phacoemulsification should be done, low vacuum, low flow rate, minimum bottle height or minimum IOP. And if possible, use a bimanual cortical aspiration for having a more controlled cortical removal. This is a case of a subluxated lens wherein the zonular damage is close to about 90 degrees. So the basic idea is that you have to perform the procedure completely and maintain the same damage, not increase the damage further. And if it does not happen, then in that case, it can be managed with an endocapsular ring. So I'm supporting the capsule with the help of, you can use a capsular hook. Sometimes if you don't get that, then you may have to use an iris hook. And for that, you have to go quite posteriorly at the limbus. And once you completely remove the cortical fibers, you can go ahead and put an endocapsular ring and then put the IOL in the bag. If the subluxation zonular dehiscence is more than that, something around close to 150, 170 degrees, then in that case, you have to fix the bag with the help of a Sione's ring. As I can see, I'm using a bimanual irrigation aspiration. A Sione's ring is used with an eyelet over the ring, and the ring is placed in the bag, and the bag is fixed. And once the bag is fixed, you can place the IOL in the bag. If the subluxation is more, you can plan for a Sione's ring, but sometimes it doesn't happen. I'm sorry, the video is not running. So it doesn't happen, then in that case, you can complete the procedure, trim this capsule, and do a one-sided fixation of the IOL. If there is a large amount of subluxation which cannot be fixed and it's a progressive zonulopathy, then even if you fix it with a Sione's ring with 2 eyelets, then also many times what happens that there is a capsular contracture and there is decentration of the IOL. So we plan for intrascleral haptic fixation, create a scleral flap and a groove adjacent to it. Then by use of intralenticular lens aspiration, the technique that was described by us in the year 2005 in JCRS, we complete the procedure, and then a multi-piece IOL is introduced and the tip of the haptic is held with a lens fixing forceps, and it is exteriorized on one side and then it's exteriorized on the other side as well, and then the haptics are tucked and the glue is used to stick it. Flax can also be useful. You can see here, this is a subluxated lens, zonular dehiscence in this area. So if you do a flax, you can slightly decenter the rexis more towards the other side. And then once you have done that, you have a free floating capsular rexis, you remove the capsule, stain inject some tricot into the anterior chamber, and then you can do a vitrectomy, remove whatever vitreous is there. And then after that, once you have removed the vitreous, then you can go ahead and complete the nucleotomy and the cortical aspiration, and then put an endocapsular ring. And once the ring is placed inside, you can put the IOL in the bag, and then it can be removed. Viscoelastic can be removed. So flax is useful in subluxated cataract. In a case of a microspherophakia wherein the zonules are intact but they are lax, in such a case, again, if the lens does not move anteriorly, if it's there in position and you can see the zonules are lax only, then you can go ahead and complete the procedure, complete the lens aspiration, put an endocapsular ring in the bag, because it stretches the capsule on all sides, and that is how it maintains the centration of the IOL. You can place the IOL in the bag. But if the lens has moved anteriorly even once, then in that case, you have to remove the lens completely and do a scleral fixation of IOL. A word about hard cataract. There are many issues of hard cataract. There can be calcific capsule, there can be, wound burn, etc. So if you have a calcific capsule, or if there's anything, you can do a femtosecond laser assisted free floating capsulotomy, and that works well. Or a lot was discussed about the small rhexis first and then enlarging it further. Here I am just showing a different technique of spiraling technique. So as you keep spiraling the capsule, then the risk of extension in these eyes is less, and you just keep doing spiraling. See how long the spiral has become, and so sometimes you even have to cut part of it and then keep on doing spiraling so that you create a nice sized capsular rhexis all around. Here you can see it's a long capsule that has come up because of spiraling, so it is being cut, and then again remaining capsule removed and capsulotomy completed. If it's a hard cataract, dividing the nucleus into two halves is the biggest trick, and for that you can chop from one side, but when you are chopping from one side, what happens that it doesn't completely separate. So you rotate it on the other side and then you chop again so that you create a complete separation. The idea is to have a complete separation. Here you can see with the movement, it does not separate completely. So again, you rotate it and bring it to the other side and do a complete separation. Once you have divided into two, then your job is almost done. That is the biggest, toughest job in a hard cataract. You can create a crater in the center, and that helps in softening the central core, and then you can chop and complete the nucleotomy. You can also do another technique that has been described as a submarine chop by Dr. Pradeep Mahanta, wherein you take a sharp chopper, dip deep into the nucleus, and then move against the phacoprobe against each other, and then you can chop it completely. Femtosecond laser has also been used to soften the central part. In this hard cataract, many times we use just the grid pattern so that you soften the central part, and then once you have softened it completely, then you can go ahead and create a crater. For creating the crater, you don't require too much of phacoenergy if you have already softened with the femtosecond laser, and then you can chop and completely emulsify the nucleus and go ahead and complete the surgery. So in conclusion, all these cases are challenging scenarios. It requires a good preoperative planning and a careful and meticulous intraoperative manipulation. Thank you very much.
Thank you, Rajesh, for highlighting all these tips for managing these difficult situations. Now I will request Manpreet to speak as fast as possible. We are over time.
A very good morning to all of you. So we'll have a rapid course on post-refractive surgery cataract. Can I have the slides, please? Not so rapid. Yeah. So no financial disclosures. So what we'll be going through are the preoperative considerations, how to get an accurate biometry and ILPAR, the choice of intraocular lens, addressing patient expectations. Intraoperatively, for post-LASIK PRK, the surgery is quite simple. Incision management in post-RK is what should be taken care of. And for post-phakic IL, how to explant them before doing surgery. Post-operative problem solving is an essential part in which periodic periphery screening should be performed and fine-tuning of the refractive outcomes. Now, looking at the ILPAR calculation, we all are aware that post-myopic PRK LASIK, there is a central flattening of the anterior corneal surface. In post-RK, there is a flattening of both anterior and posterior corneal surface with mid-peripheral steepening, and this is what is going to lead to errors in ILPAR calculation. So this is corroborated by the topography as well. So errors arise due to index error because the standard keratometric index based on a constant anterior posterior curvature does not hold true. Device error because keratometry is measured in paracentral region, not the central true flat K, and formula errors because they do not account for the ELP changes estimation. So which formula to use? There are a host of formula right from pre-history based and using change in refraction or using no previous data. Now, if you look at the recent formulas, if posterior curvature is measured or not measured, you have a host of formula, and these ones, the ones highlighted in yellow, are the one where you do not require a prior refractive history. Barrett-Truque, Hage's, ray tray-based formula, and OCT formulas are the ones which are important. You have now post-refractive IL calculators at ASCRS website, Barrett-Truque at APSCRS and ASCRS. So this has simplified life. Just put them in the online calculators. And in case of post-RK, Barrett-Truque and Hage's are the one that give the most accurate results. As a rule of thumb, choose the flattest keratometry and the highest IL power. Now coming to the type of IOL, monofocal aspheric IOLs are preferred because the myopic classic PRK induce positive spherical aberration, so choose an IOL with a negative spherical aberration. The reverse is true if you go for a hyperopic ablation because it induces negative spherical aberration, so choose a zero spherical aberration IOL preferably. Toric only if there is regular astigmatism with a repeatable magnitude and access on at least 2 different devices. Multifocal EDOF in LASIK PRK, now it is being performed. In post-RK, please avoid. In cases with minimal higher order aberrations in a regular surface in post-LASIK PRK, you still can't get away with a multifocal IOL. So ray tracing aberrometry is a useful tool while planning premium IOLs after refractive surgery. And in case you have less higher order aberrations, less than 0.4 micron, good corneal modulation transfer function and point spread, you can plan, like in this case, a toric IOL. And in this case, address patient expectations, under-promise and over-deliver. So intraoperative considerations in post-RK, incision is what is important, because if you have 4 incisions or even 8 incisions, you can get away with clear corneal incisions without transecting the RK incisions. If you have 16 or more, a posterior limbal, and in 32, a scleral tunnel is preferred, because otherwise you will inevitably transect the RK incisions and end up with a challenging phaco. So this is just a post-RK case in which we chose a 19 diopter. So intraop OCT is useful here also because you can see the depth of RK incisions and if they are at a risk of opening up. Just a case to highlight that while we were injecting the IOL, the RK incision opened, and in this case we had, now you first suture the main wound and then suture the RK incision as well. So because the fluid is going to continuously leak otherwise, so it becomes like a perf repair intra-op, but then optimal outcomes can be achieved if you manage it timely. Coming to phakic IOL with cataract, you have to explant it first. So if you have a posterior chamber phakic IOL, life is fairly easy because they are foldable and very pliable. They come out through a 2.2 or 2.8 incision, and the rest of the phaco is uneventful. So use a hand-on-hand technique, 2 microforceps, in this case 2 McPhersons, and just explant it, and then you can go ahead with the phaco as a normal. Flax has also been used and described by our center. But when you have angle-supported or iris claw phakic IOLs, if you explant them, you have to suture the incision. It is a rigid phakic IOL and requires a large incision, and then you can perform phaco via a second incision. Alternatively, you can do a phaco beneath the rigid phakic IOL with keeping it in situ. Intraop OCT, like in this case, helps you assess that there is a safe distance from the endothelium. And then at the end, after you have put an IOL, explant the phakic IOL after extending the same incision. Advantage, you are doing in a stable chamber beneath the phakic IOL, so your endothelium is also protected, and you are avoiding 2 incisions. So this is one of the modification that we have used. Flax, again, is useful in this by doing a pre-fragmentation of nucleus and a capsulotomy. Peripheral retinal screening should be done in the post-operative period. There can be delayed visual recovery, hyperopic shift after RK. So intraop aberrometry, you may have IOL surprises despite doing all the measurements and the best of things. However, intraop aberrometry is useful if you have to plan an IOL exchange or in cases in which you think even preoperatively you are unable to get an accurate IOL power calculation. This is our case in which we did an exchange. Despite all the optical biometry, the IOL power was incorrect. So just to summarize, biometry, accurate K and ELP, topographer that measure both anterior and posterior corneal curvature should be preferred. IOL power calculation, use the newer formulae, use the online calculators that now everyone has at their disposal. choice of IOL prefer aspheric monofocal IOLs, premium IOLs only if there is a regular corneal surface, minimal higher order aberrations, and regular astigmatism. Intraoperatively, incision management in RK and explant of phakic IOL is what is going to be your challenge, otherwise it's fairly simple. Post-operative consideration, counsel well, and expect a slightly delayed visual recovery or a hyperopic shift, especially in post-RK. Always under-promise and over-deliver. Thank you for your patient hearing.
Thank you, Manpreet, for doing a wonderful job. We'd like to finish this instruction course slightly late. Like to thank my instructors, Dr. Abhay Vasavalda, Subin Bhattacharya, Tushya Omprakash, Professor Rajesh Sinha, Professor Namrata Sharma, and Professor Manpreet Kaur. Thank you again for all of you. And thank you, audience, for being with us.